It's a great pleasure to introduce Dr. Manish Bansal, whom I know more than a decade. He is one of the backbone of our national IAE. Dr. Manish Bansal is a distinguished cardiologist trained at premier institutions of India like AIMS, ERIC, as well as Queensland University, Australia. He has received multiple awards and gold medals for his contribution to pathology, pediatrics, and cardiology. His expertise spans a wide range of cardiac conditions, including acute coronary events, valve disease, and cardiomyopathies. He has a special focus on early detection and management of atherosclerosis, cardiovascular risk assessment, and advanced echocardiographic techniques, including strain imaging, speckle tracking, and 3D echocardiogram. Dr. Bansal has a strong academic and research background with over 250 publications, including 145 in the indexed PubMed. He has been recognized among the top 2% of the scientists globally in the Stanford University LCR ranking since 2020. He has also contributed as the former editor-in-chief of the Journal of Indian Academy of Echocardiography and Indian Heart Journal, along with serving on editorial board for prestigious journals like JAR, Imaging, and Cardiovascular Ultrasound. We are honored to have Dr. Manish Bansal to deliver the Echo-Karnataka oration at this 20th Annual State Conference of Echo-Karnataka 2025. I request my colleague chairpersons to come over to the dais to felicitate Dr. Manish Bansal.
Good afternoon, everyone. First of all, I must say that it is an incredible honor for me to be delivering this oration here, this prestigious oration. And I thank Dr. Bohra and Dr. Satish Govind for giving me this opportunity and this huge privilege. So I'm going to talk about heart failure with preserved ejection fraction, or HFpEF as we call it. So first question is why we need to talk about this. There are many reasons why we need to talk about HFpEF. First is that today, because of the increasing age of the population and the rising prevalence of hypertension, diabetes, and obesity, HFpEF has become the most dominant form of heart failure. Now, unfortunately, we don't diagnose this in clinical practice. We miss it quite often. But if we start diagnosing it systematically, we'll realize that more than half of all patients with heart failure today have HFpEF. Second is 7% annual mortality, which means that in 5 years, 35 to 50% of the patients with HFpEF will be dead. So it's a huge mortality burden. And third is that over the last few years, there have been several large-scale randomized controlled trials which have shown that there are various therapeutic agents which can improve cardiovascular outcomes in these patients. It started with the Paragon heart failure trial with ARNI, where the overall trial was negative, but there was some subgroups of the patients whom the primary endpoint was reduced with ARNI. But then subsequently, we have had trials with SGLT2 inhibitors. Then we have trials with semaglutide and tirzepatide very recently, which have been positive trials, and the finerenone also. So because of all these reasons, it's very important that we look for this condition, we diagnose this condition, and we treat the patient appropriately. And as I said, it is the most common form of heart failure that we are encountering nowadays, even though we are not diagnosing it. So it's all around us. We have to just be vigilant. And I'll show you some examples. So this is a 72-year-old lady, had history of hypertension. She was obese. She had paroxysmal heart failure, paroxysmal AF, no diabetes. She presented with dyspnea on exertion class 2. Echo was done, showed mild LVH, grade 2 diastolic dysfunction, LA volume was increased, PA pressure was increased. So she had HFpEF, and that is what I labeled her with in the diagnosis. And the NT-proBNP level was elevated at 550. Another patient, 54-year-old gentleman, had hypertension, diabetes, and hypothyroidism. He had undergone renal transplant 5 years ago. Now presented with progressive dyspnea for the last 2 months. Vitals were reasonable. He was slightly overweight. Hemoglobin 10, creatinine was normal, anti-proBNP was elevated, and these are his echo images. So as we can see here, ventricles are normal in size, there is LVH, there is biatrial enlargement, he had restrictive mitral inflow pattern, his LV-GLS was reduced, LA volume was significantly increased, and LA reservoir strain was reduced. We did coronary angiography also, it was normal. So basically, he also had HFpEF. Another patient, 72 years old gentleman, he had diabetes, hypertension, underwent PTC stent to LAD for single vessel disease. A year later, he presented with dyspnea on exertion. He did not have any angina. He underwent stress echocardiography. As we can see here, we have apical 4-chamber view, apical 2-chamber view recorded during stress echo, baseline images, exercise images. There is no regional wall motion abnormality either at base or at peak exercise. The exercise was 7 minutes. There was significant dyspnea, no chest pain, no ECG changes. But if we look at his mitral inflow pattern and annular velocity and TR velocity, at baseline they were near normal. But on exercise, there was increase in E velocity, reduction in E prime, significant increase in the ratio of E over E prime, and increase in the TR velocity and TR gradient. So again, a case of heart failure with preserved ejection fraction, which was not apparent on baseline echocardiography, but became unmasked when we did stress echo. And in stress echo, it was important to pay attention to these hemodynamic changes, not just to the wall motion abnormalities. Yet another example here, 60-year-old lady, hypertension, obese, presented to us with class 2 dyspnea. She had LVH, biatrial enlargement, and she had all markers of elevated LV filling pressure. So as we can see here, mitral inflow pattern is abnormal, E prime is markedly reduced. We measured LV strain much later, many years ago when she presented to us again, but then the baseline images had shown LV reduced GLS also, and LA strain was also markedly reduced. It was initially overlooked. We didn't think of HFpEF as a diagnosis because this is almost a 10-year-old case, but the patient presented 1.5 years later with AF. She was in pulmonary edema and she had also suffered a stroke. Whether we could have prevented this or not, that is a different issue, but we missed this diagnosis. And today it should not happen. We should be alert. We should be making these diagnoses for the reasons that I mentioned earlier. It is a very important, prognostically important diagnosis, and we can make therapeutic changes also according to this diagnosis, which can impact the clinical outcomes. So I've shown you some examples. Now let us understand what HFpEF is and what it is not. So HFpEF is basically heart failure with LVF 50% or more. We need to remember that this condition does not include primary valve disease, pericardial diseases, infiltrative diseases, pulmonary diseases, anemia, and other high output states. So a patient with severe aortic stenosis with LVH having heart failure is not HFpEF. Similarly, a patient with amyloidosis is not heart failure, not HFpEF. Also, it is very important to recognize that even though diastolic dysfunction is the dominant pathology, cardiac pathology in these patients, it is not pure diastolic heart failure because more than half of these patients have evidence of LV systolic dysfunction in the form of reduced LV-GLS. So we can look at any trial. Here I have TopCat trial where reduced GLS, that is less than roughly 16%, was present in 52% patients. We have got many more studies, including the RELAX trial, Paragon heart failure trial, and many other trials which have shown that abnormality of LV-GLS is quite widely prevalent in these patients. So they have LV systolic dysfunction also. They have LV diastolic dysfunction. But actually, heart failure with preserved ejection fraction is much more than that. It is not just a disease of left ventricle. It is actually a very complex disease characterized by multiple abnormalities. So patients have LVH, they have LV diastolic dysfunction, they have LV systolic dysfunction. There are patients who've got arterial stiffness, endothelial dysfunction, there is vascular inflammation. There are some patients who've got more marked LA abnormalities, pulmonary hypertension, RV dysfunction, and so on. And some patients are quite fluid sensitive. They have fluid retention. So because of these multiple abnormalities happening in these patients, this becomes a very heterogeneous conditions. Different patients present with different abnormalities dominating in them, resulting in different phenotypes of this condition, which make the diagnosis of this condition challenging, and treatment of this condition has also been challenging. As I showed you that only recently we have had some trials showing benefits. Earlier we did not have any specific treatment for this condition. And this is also reflected in how patients die with this condition. So if we compare trials with HFrEF versus those with HFpEF, we find that whereas roughly 80% of all mortality in HFrEF is due to cardiovascular causes, in HFpEF only 50 to 60% mortality is because of cardiovascular causes. 40 to 50% patients die because of other conditions also. So this just to highlight that this is quite a heterogeneous condition. Okay, so now that we understand that what we are dealing with, how to diagnose it. So let me make it clear that HFpEF is not a diagnosis of echocardiography. It is a clinical diagnosis. Since morning we are talking about how clinical context is important. This is one condition which exemplifies this whole concept perfectly. So we need clinical assessment, we need laboratory markers, we need echo findings, we need much more than that to reach a diagnosis of HFpEF. But as echocardiologist or echocardiographer, it is our responsibility to provide all the required information which will make the clinician reach that diagnosis of HFpEF. So to diagnose it, first is to suspect this condition. So who are the patients who have HFpEF? So if we look at the major randomized trials of HFpEF versus HFrEF, we find that patients with HFpEF typically are elderly, they are older, more women, high prevalence of hypertension, they are relatively overweight or obese, atrial fibrillation is much more common, CAD is much less common, and they may present to us with metabolic syndrome, diabetes, although the differences with HFrEF are not that common, but these conditions are prevalent. And anti-proBNP levels in these patients are relatively lower as compared to HFrEF. So basically, if a patient comes to us who is elderly, obese, especially women, history of AF or OSA, we should be suspecting HFpEF. Now, once we suspect HFpEF, what we need to diagnose it? There are essentially three elements that are required for reaching this diagnosis. First is that we need to show that the patient is having heart failure. Second is that there should be some structural or functional cardiac abnormality which can explain heart failure, like LA enlargement, LV hypertrophy, or evidence of raised LV filling pressure. And third, the EF should be 50% or more. If we satisfy these three conditions, we can make a diagnosis of HFpEF. But here is the challenge. Although it is easy to say that, okay, the patient should be having heart failure, but proving it is difficult. Like a patient comes to the OPD, has dyspnea, obese, and the typical profile that I described. How do we say that the patient has heart failure? And therefore, to be sure of that, the guidelines recommend that we corroborate this assessment with either anti-proBNP or BNP, or some objective evidence of heart failure like raised JVP, basal crepitations. Pedal edema alone is not sufficient because pedal edema can occur because of a variety of conditions. So according to the guidelines, in ambulatory patients, if anti-proBNP is more than 125 or in hospitalized patients more than 300, we can label the patient as having heart failure. So this is the simplistic approach to diagnosing heart failure. And something similar has been used in the randomized trials also. I have two examples here, Emperor preserved with empagliflozin and Deliver with dapagliflozin. In both these trials, something similar was done. Patients with dyspnea or history of heart failure and structural changes in the heart in the form of LA enlargement or LVH and elevated anti-proBNP. These were the eligibility criteria for inclusion in these trials. Now here the cutoff value of anti-proBNP that was used was much higher. 300 in patients without AF and 900 or more in patients with AF. So the higher cutoff value was used for increasing specificity of the diagnosis and to be able to show the benefit of the therapies. In our busy clinical practice, we can use these same criteria for diagnosing HFpEF, and it will do a good job for us. But we need to remember that there are many caveats to this, and this study from the Mayo Clinic shows why. The studies have shown that there is no single parameter which is accurate enough for the diagnosis of HFpEF. So I talked about NT-proBNP, but NT-proBNP levels are often normal in these patients. Why? Because their EFs are normal, their LVH is common. Because of LVH, wall thickness is high, wall stress is not that much. So NT-proBNP levels do not go up to that level. So in this particular study, 23% patients had NT-proBNP levels less than 125 and 40% patients had NT-proBNP level less than 275, which means that if we are using a cutoff value of 300, we will end up missing 40% of our HFpEF patients. And same is true for echo parameters also. There is no single parameter which is accurate enough for this diagnosis. So we have to use all the different parameters for a comprehensive assessment and for reaching the diagnosis. This one study just shows how NT-proBNP levels are lower in patients with HFpEF as compared to HFrEF. And with increasing body weight, the discrepancy continues to increase, because in obese patients, pericardial restraint further reduces wall stress, and the NT-proBNP levels do not increase that much. So, and most of the patients with HFpEF are obese, and therefore NT-proBNP levels may be normal. So I showed you the eligibility criteria that were used in the major randomized trials. We can use them. We will still do a better job than what we are doing currently. But if we are more careful, more vigilant, and we want to be more precise, we can do even better. This is a slide from Paragon heart failure. Just shows the same thing, that echo findings are also not very sensitive or specific for diagnosing this condition. For example, here LVH was present in only 19% patients. This was a trial on patients who had HFpEF. Only 30% patients, only 55% patients had E over E prime more than 15. So in 45% patients, E over E prime was normal. So what to do? So to overcome this limitation, two different algorithms have been proposed by two different sets of investigators. One of them is this H2FPEF. This is a scoring system based on these 6 parameters: BMI, hypertension, AF, PASP, age, and Doppler E over E prime more than 9. And these are the scores. If we add them, we can get a score from 0 to 9. If the score is 6 or more, it is highly diagnostic of HFpEF. So this is one simple method that we can use. The other one is recommended by the European Society of Cardiology, HFpEF score. So this involves 4 steps. First is we have to have pre-test probability of having HFpEF. So the typical clinical presentation, an echo showing LVH or L enlargement. Then we do a more comprehensive assessment using echo and natriuretic peptides. So these are the parameters that we should be looking at: E prime, TR velocity, GLS, LA volume, LV mass index, relative wall thickness. So all these are included, and natriuretic peptides. Depending on the values that we get, we can score these abnormalities and get a composite score. If the score is 5 or 6, then it is a very highly probable for HFpEF. If the score is 0 or 1, then that means that there is no HFpEF. When the score is 2 to 4, then that indicates intermediate probability. If we come across intermediate probability situation, then we need to do functional testing, either stress echocardiography or cath. Cath is the gold standard, but it is not practical. We cannot do it that routinely. So stress echo becomes the most useful modality in this setting, and I showed you an example of that in the previous slides. So if you are doing stress echo, if on exercise patient's E over E prime increases beyond 15, with or without increasing the TR velocity more than 3.4, we can be reasonably certain that we are dealing with HFpEF. So these are the two different algorithms that we can use in our daily clinical practice to diagnose HFpEF. So all those who are doing echo, I know that many of the attendees here are sonographers. So my request to them will be that whenever you see a patient who comes to you with a diagnosis of dyspnea, is undergoing evaluation for that, and you don't find any obvious cause in the form of a valvular disease or alveolar systolic dysfunction, then always look at LV mass index, LA volume, GLS, LA strain, TR velocity, report all of them so that the clinician can use that information for reaching the diagnosis of HFpEF. Now, I showed you two algorithms. We can use either, but a sobering point here. A recent study compared the two algorithms in the same group of patients. From Eric's study, patients had unexplained dyspnea, 640 patients. Now, unfortunately, only 4% of the patients were identified as having high risk for HFpEF using both the algorithm. So there was a lot of discordance. But the good thing was that whichever algorithm was used, when it had high score, then the risk of adverse events was very high. So what it means is that we can use any algorithm. If that shows that high risk for HFpEF, then the patient is at high risk of having adverse events. We need to be very careful in dealing with that patient. We need to optimize all the treatments that we can do. Now, in future, a lot of advances are happening which will make the diagnosis much easier for all of us. Like machine learning is coming up a big way in this. This is a very recent paper, just a few months old, in which the investigators looked at clinical parameters, echo findings, and EGFR to develop a prediction model which had 88% accuracy for diagnosing HFpEF as compared to H2FF score which had 74% accuracy. So significant improvement. Another paper published last year. Here the investigators looked at only apical four-chamber view. No clinical information, no laboratory markers, no other echo finding, and just use this parameter, this single view, to diagnose HFpEF, and they could do it very accurately. Yet another modality which can help in this field is shear wave elastography, which uses very high frame rate echo, 5,000 frames per second. Using such a high frame rate echo, we can measure the speed at which shear waves travel along the myocardium, and it appears to be a very promising technique for diagnosing HFpEF. So all these advances are happening, which will make the diagnosis of HFpEF relatively easier in future. But for the time being, we need to use all the available information and reach a diagnosis. So once we have looked at clinical parameters, laboratory parameters, routine echo, and in some patients stress echo, we can be fairly confident that, okay, we are dealing with HFpEF. At this stage, the next step that becomes important is to rule out mimics of HFpEF. Like we need to rule out non-cardiac mimics such as kidney disease, liver disease, or chronic venous insufficiency. A patient with CRF may also have dyspnea, will have pedal edema. We need to be careful. Patient with cirrhosis can also present with the same symptoms. Once we rule out these non-cardiac causes, then we have to rule out cardiac causes, which I mentioned in the beginning itself, that HFpEF does not include valvular heart disease. It does not include hypertrophic cardiomyopathy or any other cardiomyopathy. Once we do this, then we can give the label of HFpEF. Okay. Now, for most of the clinical purposes, we can stop at this point, and we have diagnosed HFpEF, we can treat the patient accordingly. But there is much more to this, and those who are more interested into that, in those aspects, can delve further. So studies have shown that, as I mentioned in the beginning, HFpEF is a very heterogeneous condition. So patients with HFpEF present with distinct phenotypes, and these distinct phenotypes have different clinical trajectories. Like this is a slide from iPreserve trial, and this is Charm Preserve, both trials conducted in HFpEF patients. So it's the same group of investigators looked at 11 different parameters and diagnosed and used those parameters to categorize patients into 6 different categories. And in both these trials, the patients who were in category C or category F had the worst outcome. So what were these categories? Category C were patients, elderly patients, high rates of obesity, diabetes, dyslipidemia, CAD, anemia, and renal dysfunction. Category F was predominantly elderly women, 80 years or older, frail women, high rates of AF, some valve disease, renal dysfunction, anemia. So these were the two groups which had the worst outcome. But then there are many other studies which have shown that patients can be categorized into different groups differently. Once we categorize patients into different phenotypes, there are phenotype specific differences in the treatment also. We can use specific strategies to manage those phenotypes to improve the outcomes. These can be either on the basis of etiology or can be on the basis of clinical presentation, like whether the patient has only exercise-induced rise in LV filling pressure, patients who are volume overloaded, patients who present predominantly with right heart failure, HFpEF. So we will treat these patients differently. So to understand all these, we need many more parameters from echo, which we can easily provide. Like we can quantify LA function very beautifully with the current techniques. We can use LA strain, and we know that LA strain has incremental value over LA volume index. So in all patients with suspected HFpEF, we should be doing LA strain measurement. LA strain can detect abnormal filling pressures with greater sensitivity as compared to LA volume index. There is another parameter known as LA compliance, which is easy to measure. It is a ratio of LA reservoir strain divided by E over E prime ratio. So in this study, resting LA compliance had accuracy of 0.81 and exercise E over E prime also had accuracy of 0.81, which means that if you can measure LA compliance, then you don't need to make the patient do exercise. You can do away with the need for exercise echo for diagnosing HFpEF. There are many patients who present with predominant right heart failure. So characterization of right heart function is very important in these patients. And one useful parameter here is RVPA coupling, which is nothing but a ratio of TAPSE to PASP. So here I have example, TAPSE measured from M mode and PSP from Doppler. Ratio is 0.33. The studies have shown that patients who have this ratio less than 0.36, they have poorer survival, higher event rates. Now, once again, machine learning modalities are playing important role here. There are a lot of studies currently underway to phenotype these patients. So we have machine learning for diagnosing HFpEF. We have machine learning also for phenotypical characterization of these patients. All this will change the future diagnosis and evaluation of HFpEF patients. We will be using different modalities, laboratory parameters, clinical parameters to more accurately diagnose HFpEF, more accurately characterize them to guide more precise treatment strategies. So precision medicine at its best is what we can look forward to in future in the field of this particular clinical entity. Just to summarize, HFpEF is common, but it is quite often missed. Clinical suspicion is the most important. Clinical features combined with the natriuretic peptides and comprehensive echocardiography will allow diagnosis of HFpEF in most of the patients, but a more nuanced diagnosis needs expertise. Thank you so much.
Now, what was the need to revisit? Still remains a problem. It's often still underdiagnosed or there is a delayed referral. And when to intervene in patients who are asymptomatic is still a question. And as Sir was mentioning, assessing the suitability for BMB and what are the parameters that have to be assessed on follow. And as echo is evolving, there are parameters by which we can predict the thromboembolic risk. So, rheumatic MS echocardiographically by the World Heart Federation has been defined as a transmitral mean pressure gradient of more than 4 millimeters of mercury with typical morphological changes in the valve consistent with the rheumatic process, as in thickened mitral leaflets or commissural fusion or restricted leaflet motion or diastolic doming of the AML or caudal thickening or calcification. Now, this is stages of MS which has been given by the ACC-AHA 2020 guidelines, wherein it is staged from stage A to D, that is from being at risk of mitral stenosis to having symptomatic severe MS. Now, echocardiography plays a major role in the confirmation of diagnosis, in quantitation of stenosis severity, in assessing the secondary effects on the LA, LV, and the right side of the heart, in analyzing the valve anatomy and thereby helping in decision making, and also in guiding during BME. The various modalities at our disposal are 2D echo, 3D echo, transesophageal echo, stress echo, strain imaging, and fusion imaging. So on the 2D, the M mode, that is the thickened mitral leaflets and paradoxical anterior motion of the PML, reduced mitral leaflet excursion and decreased EF slope, doming of the anterior mitral leaflet with a hockey-stick appearance. And because of the commissural fusion, there is a fish mouth appearance in the parasternal short axis view and an off-axis view, which is showing the submitral fusion. Quantitative assessment involves the planimetry and the pressure half time. Also has the continuity equation PISA methods, but these are usually time consuming and also prone to errors and not done in routine practice. And also we have the mean pressure gradient. The planimetry of the valve is done in the parasternal short axis view, and this is actually the most best way of assessing the severity of the valve. Also because it is not affected by flow rate or chamber compliance or any associated other valve lesions. But sometimes because of distortion of the anatomy or because of improper tomographic planes, we may not be able to get the exact valve area. This can be circumvented by using a 3D planimetry. The pressure half time, which is nothing but the trace of the deceleration slope of the E wave of the transmitral gradient. This can also be taken for assessing the severity. And the candle flame appearance, which is typically seen in mitral stenosis. And the mean pressure gradient being more than 10 millimeters of mercury is graded as a severe MS. Now coming to the secondary effects that it has on the LA, that is the LA dilatation is noted, because of which there is an increased incidence of atrial fibrillation and thromboembolism because of the formation of clots. The secondary effects it has on the RV can be estimated. Actually, it is most of the time on 2D echo difficult to analyze the RV. But the factors that we can take to look for RV dysfunction are the fractional area change, which will be less than 35%, or the TAPSE less than 1.6 is taken as showing RV dysfunction. A tissue Doppler imaging where the S prime is less than 10 centimeters per second. And also we can calculate the tie index. On the pulmonary circulation, we can interrogate the TR jet and get the pulmonary artery systolic pressure. So on 3D echo, actually we get a more precise quantitation of the mitral valve area. Biplane imaging and multiplane reconstruction allow for accurate localized location of the smallest MV orifice. Even in the presence of heavy calcification, 3D imaging will allow clear imaging of the orifice. So this is the biplane imaging of the mitral valve, wherein in the parasternal long axis, we note that the cursor is placed at the tip of the mitral leaflets, and simultaneously a short axis view is provided so that we are analyzing the mitral valve at the tip of the mitral leaflets, and we get the most nearest exact planimetry of the valve. These are some real-time 3D images showing diastolic doming of the AML, the characteristic fish mouth appearance, and also the submitral fusion. However, there are some limitations because the image quality is dependent on an adequate acoustic window. Suboptimal temporal and spatial resolutions are an issue, and image acquisition is often prone to stitch artifacts, which is common in patients with rhythm disturbances, more so in MS because there is associated AF. Transesophageal echo, we would be evaluating the LA and the LA appendage thrombus, and also we get a chance to interrogate the LA appendage for the LA appendage velocity. So this is the classification by Manjunath et al. Of the LA clot, wherein we classify it from type 1A to type 4. So these are some of the representative examples of type 1B, type 3 and type 4 clots. And LA appendage velocity interrogation, this is actually functional imaging. Normal velocity is between 50 to 60 centimeters per second. It's a predictor of thromboembolic risk. So this is a picture which is showing a normal LA appendage velocity, and the second picture shows a patient in MS with sinus rhythm where the LA appendage is around 20. So presence of LA dysfunction it is shown to be a strong predictor of thrombus formation and embolism, and even in the absence of AF, LA dysfunction is found in patients with significant MS. So stress echo is basically done in patients whose symptoms are incongruent with the echo data. So basically identifies patients who might benefit from intervention. And also it helps in risk stratification of patients with MS, as in before a major surgery or if somebody is planning pregnancy, to predict their hemodynamic reserve. So options available are exercise or dobutamine stress. Exercise stress is more physiological. And a transmitral gradient of more than an increase in transmitral gradient to more than 15 millimeters of mercury, and a PASP of more than 60 millimeters of mercury is considered to be hemodynamically significant. Strain imaging, It is noted that in mitral stenosis, most of the time there is a subclinic evidence of subclinical LA, RV, and LV dysfunction. So, reduced peak LA strains have been noted to predict symptoms as well as hospitalizations, onset of atrial fibrillation, thromboembolic events, and also need for valve replacement or BMV at 3 years in asymptomatic patients, even with moderate mitral stenosis. And also, improvement in this LA, RV, and RV strain has been noted post BMV. These are some pictures which show the peak longitudinal strain pre BMV in the LA, which has improved post BMV. And this is in the LV pre BMV, which has improved post BMV. Fusion imaging, this is basically fluoroscopy and TE guided or co-registered for balloon mitral valvotomy. The first picture is showing the TE guided intervention for BMV. So this is the 30 to 45 degree angle wherein the arrow is showing at the needle for the transeptal puncture. So in this 30 to 45 degree orientation, we get an idea about the anterior and posterior location. And in the 90 to 120 degree, that is in the second picture, that is gives us a superior and inferior orientation. And the 0 degree, at the 0 degree angle, we know how high we are from the mitral valve. Coming to assessment of valve anatomy for suitability of balloon mitral valvotomy, there have been various scores so far, but still the Wilkins-Weymouth scoring system, which was proposed almost more than 30 years back, is still used. So here there are 4 parameters, that is the leaflet mobility, thickening, calcification, and subvalvular thickening, which are taken into account. And a score of less than 8 is found to predict favorable outcomes in the immediate and long term. But however, there are some caveats to this. The problems are there is a lot of inter-observer variability, and the another issue is this does not involve the commissures. It does not comment about the commissures. So the prediction of MR is not there with this score. So there were some scores which would predict the risk of MR post BMV. This is one of them is the Nunes score, which takes 4 parameters. That is the mitral valve area, the maximum leaflet displacement, the commissural area ratio, and extensive subvalvular involvement. Now, leaflet displacement is basically the displacement from the annulus to the maximum doming of the valve, and the commissural area ratio is tracing of the area of the mitral valve, that is the inner area and the outer area in the parasternal short axis view, and drawing an intercommissural line and bisecting it and taking a ratio of the maximal to the minimal area. It has been noted that CAR value of more than 1.25 predicts that there will be an increase in MR by 1 grade following BMV. And value less than 3 is associated with favorable outcomes post BMV. Another score is the Sutaria score, which looks at the commissural calcification. And if a score of 0 to 1 has favorable BMV outcomes, whereas a score of more than 4, wherein there is bilateral extensive calcification, BMV is contraindicated. Also, we have the 3D valve score by Anwar et al., wherein severe mitral valve involvement, that is, if there are more than 14 points, then there are suboptimal outcomes. So basically, what are the determinants for favorable outcomes in BMV? Though there are several scores, what is proposed is to have an integration of these scores because each score has its own fallacy. So if we grade a patient on the Wilkins score as being less than 8 for optimal outcomes, we can add on the Nunes score to it to look if there is any increase of risk of MR in those patients. And those patients having a Wilkins score between 9 to 11, wherein we expect intermediate results with a Wilkins score, we can add on the Nunes or the Sutaria score to predict favorable outcomes. Another concept is the use of a multifactorial score, because all these are just anatomical scores. We also need to look at the hemodynamic and clinical parameters, because those patients who are less than 55 years of age, the male sex, patients having a MVOA of more than 1 centimeter square, an MR less than grade 2 plus, and a lower NYHA class also have favorable outcomes. So it needs to be individualized. So contraindications for BMV, as all of us know, bicameral calcification, moderate MR, a persistent LA body clot, that is presence in spite of adequate anticoagulation for 8 to 12 weeks, if there is a persistent LA body clot, absence of commissural fusion, and if there is presence of severe concomitant aortic valve or tricuspid valve disease or coronary artery disease, then the patient goes directly for surgery. So another concept is a low flow, low gradient mitral stenosis, wherein the MVOA is less than 1.5 and the stroke volume index is less than 35 ml per meter square. Now these patients basically have a higher level of subvalvular obstructions. They are more elderly, and they have also a high prevalence of AF, and results of BMV are found to be suboptimal in these patients. Follow-up of these patients is important to prevent irreversible consequences on the ventricles and pulmonary circulation, which may occur sometimes in the absence of symptoms. And any new onset or recurrence of symptoms or a change in physical examination should always raise concern and warrant an echo. So to conclude, echo is the gold standard to diagnose and assess the severity. Severity should be quantified using either 2D or 3D planimetry. Stress echo helps in risk stratification. Strain imaging can help in prognostication and predicting the thromboembolic risk. And an integrated scoring approach is better to predict favorable outcomes in BMV. Thank you.
And my dear colleagues and delegates, I know I'm standing between you and lunch, so I'm aware of that. So I'll be little brief. My talk is little offbeat because I'm trying hard to correlate with echocardiography, but it's been difficult. But anything we deal with or speak in cardiology has some correlation with ECG or echocardiography. So that's what I believe in. So because ECG and echo is the essence of cardiology. And treating a cardiac ailment, it means like you have a lot of medications. It's almost like a mini meal for the patient. And this causes a lot of compliance issues, psychological stress. Apart from that, economics is also involved. Many of them are not able to afford. So both from the patient point of view and from the physician point of view, there is always a search for cheaper alternatives. These cheaper alternatives, is it wise and justified to go for these cheaper alternatives, will be the essence of my talk. These innovator drugs. So the innovator drugs are the first version of the medication that is sold in the market. We are sure about the active substance in the drug, and it has undergone extensive testing and research before being submitted for approval, and it's approved by strong regulatory authorities like FDA. So it undergoes a lot of, it takes a lot of time for development of this drug and for the regulatory approval. It's close to about 10 years before the safety and efficacy of the drugs are proven, and it costs a lot also. So FDA approval means it has to undergo phase 1, phase 2 trials, phase 3 trials, then review meetings, and applications are reviewed. Right from drug labeling to facility inspection, everything, it undergoes a very, very stringent process. Why is this FDA approval important? That is because we are sure about the data of the drug that is there, and we are sure about the benefit that it offers, and we know that it outweighs the potential risks and the potential risks in the intended population. What are the USPs of the innovator drug product? The shape, size, color, the scoring configuration. If you split it into two, you are very sure that 50% of the drug is there in each half of the drug. The excipients that are there, the established safety, efficacy, packaging, manufacturing process, the expiration time and labeling, everything is quite reliable. So what are the challenges in heart failure? The prevalence of heart failure has been steadily increasing, and 25% of the patients are readmitted within 30 days of discharge, and half of the patients are readmitted within 6 months, and 50% of patients die within 5 years of diagnosis of heart failure, and this mortality is much higher than colon cancer, breast cancer and prostate cancer put together. What about heart failure in India? It's a bigger challenge because heart failure occurs at a relatively younger age, and the in-hospital mortality and the 6-month mortality is also very high in Indian population. So while there has been a considerable success in the past 2 decades, there are a lot of unmet needs. So this was the flow chart where it shows the various heart failure therapies that have been developed. There was a lot of lull between 2001 to 2014. For more than 10 to 12 years, we did not have any kind of newer effective drug that was found till the availability of this ARNIs. So these were the big three till the very late, till 2014 or so. Beta blockers, mineralocortical receptor antagonists, and AC inhibitors or ARBs were the three biggies that were available for heart failure management. Here we can see that beta blockers and mineralocortical receptor antagonists, they reduce the mortality to a great extent, but AC inhibitors and ARBs did not offer the same. It means that there was a lot of untapped thing, and it offered only modest effects on survival. So there was some missing link with the AC inhibitors and ARBs, and the answer was, the missing link was this natriuretic peptide system. In the pathogenesis of heart failure, we know sympathetic nervous system and the RAS system plays a very important role, and inhibiting in sympathetic nervous system and RAS system has been quite effective. But there is one more system called the natriuretic peptide system, which is also equally important. Natriuretic peptides play a very important role. They have a lot of beneficial effects as far as pathogenesis of heart failure concerned, including reducing the fibrosis and reducing the hypertrophy of the heart. But nesiritide failed as a drug for natriuretic peptide system, and the only hope was the neprilysin. Neprilysin is an enzyme which degrades the natriuretic peptides. But the problem with neprilysin was it also inhibits the angiotensin degradation, and thereby it inhibits it prevents the inhibition of RAS system. So there is counteraction between the two, and effectively they do not help in heart failure. So if neprilysin inhibition has to be there has to be simultaneous RAS blockade also. So hence what they did was they could not use neprilysin inhibition alone. So they tried to combine it with AC inhibitors, but again that resulted in a lot of side effects in the form of angioedema. So the next answer was combining the neprilysin inhibitor with a ARB. And that is how ARNIs came into the fore. And this combination of valsartan with sacubitril effectively inhibited both the neprilysin and the RAS inhibition, and it resulted in robust benefits. Right from it acts on the underlying structural and molecular abnormalities which drives the disease progression that is silent and life-threatening. So it was a wholesome care for the heart failure patients. So the innovator ARNI has changed the face of heart failure treatment. It's a unique molecule that is there. And is there any scientific evidence for this? The Paradigm heart failure trial, it compared the ARNI with AC inhibitors, and it showed that it is much, much more beneficial as far as mortality and morbidity is concerned. How did it affect the guidelines? Within a couple of years after introduction of ARNI, the innovator molecule, in 2016, both the ESC and ACC came up with ARNI as a class 1 recommendation in patients with chronic heart failure. Can it be used in an acute setting? Yes, the latest data says, as per ACC 2024 consensus, it recommends directly initiating an ARNI. When a patient with acute heart failure comes, no need to start them on AC inhibitors or ARBs. You can in fact directly start them on ARNI. So this is corroborated by the Indian consensus statement also. So when a patient comes with acute heart failure, so one of the first drug to be started will be a RAS inhibitor, and preferably ARNI scores over AC inhibitors and ARBs. Then comes beta blockers, MRAs, and even SGLT2 inhibitors. What is the differences between an innovator drug and a generic drug, specifically with ARNI? An innovator drug is backed by strength of evidence, and it follows extensive research. So look at the difference here. The innovator drug has to undergo a lot of animal studies, clinical studies, and bioavailability. Whereas the generic drugs has to just prove bioequivalence. So what does bioequivalence mean? When you are giving two pharmaceutical drugs in similar concentration, they are absorbed and they are available in the blood for effect. So this is what bioequivalence means. Whether this converts into clinical efficacy and whether it proves safety is not reliable as far as bioequivalence. You would have heard a lot of them speak about it's a bioequivalent drug to the innovator, but that does not mean it has similar effects with the safety and efficacy. So, and these bioequivalence studies are often conducted only in healthy adult volunteers rather than the patients in whom the drug is intended to use. And there are a lot of inactive ingredients which are present in the generic version. These small changes and impurities in these excipients may result in unexpected adverse effects. So, it may not be prudent to use these kind of generic drugs where apart from the active drug, the other incipients that are there also matter a lot. And some of the data shows that about 1/3 of the patients, whenever they switch from an innovator to a generic drug, they reported some kind of allergic reactions or adverse events, and this resulted in negatively impacting the medical adherence and thereby poor clinical outcomes and more adverse events. So, if we just go by the cost, increased total cost of care with an innovator drug, it may be counteracted by increased physician visits and hospitalizations. And this particular study, the meta-analysis showed that there is 14% increase in all-cause hospital visit which was observed when generic drugs. Hence, selection of a right RNA for a heart failure with reduced ejection fraction patients is extremely essential. So, the innovator RNA is a unique salt complex, and this particular innovator drug, it has a perfect combination, 1:1 combination of sacubitril and valsartan. We know a balance between the two is extremely important. It has optimal physical properties, it has a simplified manufacturing and processing, and it has improved bioavailability, and it has a unique mode of action. So, has there been any comparison between an innovator and the generic drug? So, there was one particular study where they compared between the innovator drug and 16 generic brands of RNAs that are available, and they were tested for dissolution profile, sodium content, and melting point. What is this dissolution profile? It dissolves nicely, and within a few minutes it is available for action. If a drug dissolves nicely, it means that the effects are predictable, consistent, and reliable. So, this study showed that only the innovator had good dissolution index. Coming to the sodium content. So, every RNA drug, it has some amount of sodium. This sodium is important to achieve better physical and chemical stability, hygroscopicity, and handling and storage. This is very constant with the innovator drug at 1.72% only, whereas with the generic brands, it is much, much higher. If sodium content is high, it means we know that when sodium is high, it can cause salt and water retention, and it can worsen edema in heart failure patients. So, that is one more point. And thirdly, the melting point of the innovator RNA is much, much different from the other generic drugs that are available. So, if a melting point is high and constant, it means the compound is more pure and it is a well-defined material, and it indicates stability of the compound. So, innovator RNA has an unmatched legacy. It has 8 years of positive clinical experience. It has been evaluated in up to 230 clinical trials. It has been studied extensively in more than 3 lakh patients, of which about 1,500 were Indian patients as part of global clinical trials, and it is trusted worldwide with 78 lakh patient years of exposure. So, the innovator RNA also won the prestigious 2016 award. It's one of the highest honors for any pharmaceutical products, where it was considered as the first new treatment for heart failure in the last 15 years. So, concluding, innovator RNA has a proven efficacy and safety over 8 years. It has also impacted heart failure guidelines, giving the first line recommendation in heart failure with reduced ejection fraction patients. So, when it is a critical situation like a heart failure, where small changes in the LV indices or LA indices or the volumes can cause a significant difference in the clinical outcomes, in the ejection fractions, and the morbidity and mortality of heart failure patients, we should not be taking a chance. We have to rely more on the innovator brands. Thank you all for your patient hearing.